One of the focuses that we try to come up with is what are the things that are going to be the most pressing issues at the time the conference is happening. Last year in Philadelphia was right when all the Ebola things hit, but it's still enough of an issue that we felt it was worthwhile to have the plenary session we had last night. I don't know if you had a chance to go, but Ian Crozier was just amazing. Just to hear that perspective. He's doing a Meet the Professor where he's going to talk more about the nuts and bolts of when he was really sick. And then to see the molecular testing that's been able to be done to find out how the virus has been transmitted, as well as what's happening to try and figure out how to contain it and how better to respond to things. You're not going to find that anywhere else. And it's got important lessons with how we respond to other things in the future. That's part of why we picked pandemic influenza as the closing plenary, because that's something we have every year. And as you probably noticed or heard about, the vaccine last year was really not that protective. I think the efficacy for influenza A, H3N2 was on the order of 18%, when normally it's 40 to 50% in preventing illness. There's an interesting abstract that I think is a poster that shows in Michigan, I believe, that the efficacy was in that area more on the order of 40%. And in fact, it actually had a lot of benefit in preventing people that had been vaccinated who ended up being hospitalized didn't end up in the ICU as often and weren't as sick. So it still had some benefit. It's hard to pick out. The efficacy estimates come from different sentinel sites that the CDC sets up, and it's whatever is happening in those areas. And I think there were mixed numbers of how much of the drift variants there were. It was a great vaccine against influenza B, and what typically happens in my area is that we see a bunch of A in December, January, February, and then we have a lower peak of B a little bit after that. And it was very effective against B. It just sort of points out the problem with the vaccine. Two problems. One is not enough people get vaccinated. So if you have a lousy vaccine in terms of efficacy, but you vaccinate many more people, the chance of having a bigger epidemic is lower anyway, because you have better herd immunity. And it also points out the fact that the strains that are in the vaccine are educated guesses based on what's circulating in the Far East about 6 months ahead of time, and they're not always right. And the way it's made is so cumbersome that it takes about 2 to 3 months to go from picking the strains to getting a vaccine, and you can't really nimbly respond with that. So it calls out for more work on different ways of making the vaccine, molecular methods, and there are a couple, but there are things that could be scaled up faster. The thing I know the most about in terms of HIV is the outbreaks they had in Indiana, where they were able to show that getting in there and doing interventions that we all know work, which is needle exchange and talking to people about behaviors that increase their risk, made a big difference. It turns out that it was a group of people, sort of a network of people that were using drugs that already had a high incidence of hepatitis C. And then, there were incidences where there'd be 7 or 8 people sharing a needle, and it shows you that there's a lot of areas where public health can intervene to stop things like that. We know enough about how that virus gets transmitted that we should be able to stop it, and we have enough drugs now that we should be able to stop it with them as well. So it's kind of it's not surprising that there's sort of little bubble ups like that, but it points out where public health infrastructure is really helpful. It's much more of an integrated meeting than it used to be. The first couple of years, it was sort of like having the SHE meeting and the IDSA meeting together next to each other, which is kind of one of the things I've tried to do since I've been on the committee, which is to do more collaborative work so that we don't just have a symposium that applies to one narrow focus of infectious disease clinicians. It brings in people that primarily do epidemiology, and you try to focus it around an issue and get all the different points of view together, and that way you get people talking to each other that wouldn't necessarily normally interact. And it's every year it's gotten to be more, it's a very clinically oriented meeting, yet there's still a lot of basic science that gets put forth here in terms of mechanisms. So for instance, the What's Hot symposium that I moderated yesterday has half-hour talks by a basic science HIV researcher, a clinical HIV researcher, and the same thing for general ID. And so it's sort of a juxtaposition. The nice thing about the basic science people is they did a really good job of framing the relevance for this, because it's very hard to sit there and look at all kinds of sequences and, you know, slides that have minutiae you can't even read, and, you know, not really have an idea of how relevant things could be to clinical practice. And I think that's one of the things this meeting does the best, is it focuses on how we're going to take these things and make our clinical practice better.